I'm very happy to introduce Vlad Ratziu. Floor is yours.
Thank you, Bart. Also, Amalia, for the invitation. First, do you hear me?
Yes.
Second, do you see my screen?
Yes.
Okay. So, oh, choose another typo. Very bad moment to give this talk because it's not a highly optimistic time to talk about the NASH pipeline for reasons that are not scientific, but for which we might go into a little later. However, I sort of prepared some sort of overview of the topic. It's impossible to talk about all the molecules, and maybe not even very useful since many of them are sort of standby, not truly in development. But I chose a few which are I think are really indicative of how wide this field is and how fascinating all these mechanistic links between the liver disease and the outcomes or the metabolic condition are. So as you know, probably the biggest theoretical advantage or advance in the past few years has been the description of a registration pathway for drugs for NASH. And that includes, once you get into pivotal phase 3 trial, the demonstration in the short term that the drug has an effect on histological endpoints. So those histological endpoints, which are those shown here, actually are only surrogates. But many studies have shown that these surrogates are probably have something to do with the progression of the disease. So if after a period of 12 to 18 months, a drug is able to show a higher ability versus placebo to meet one or both of these endpoints, then in theory, this will lead to conditional approval of the drug. And this is important because really it's a strong enticement for drug development in this area. It allows drug companies to put these drugs on the market very fast, and also it allows patients to get a treatment much faster. But in order to have a definitive approval, what needs to be shown is that achieving these histological endpoints really translates into clinical benefit. And that can only be shown with a much longer period of treatment and with hard clinical outcomes, such as mortality, cirrhotic complications. Now, another facilitating factor here was the fact that the agencies agreed that progression to cirrhosis itself, which is still histologically defined, it is to be considered as a clinical endpoint per se. And that certainly will facilitate the achievement of the clinical endpoints. And if that is the case, that will bring, in theory, it never happened so far, definitive approval. It will be very interesting to see whether our hypothesis, which is what underlies these registrational trials, is verified. And this hypothesis being whether resolution of NASH or having fibrosis go back by one or several stages truly does translate into clinical benefit. For the moment, this hasn't been shown directly. Now, it is very depressing because, well, one failure is interesting. Two failures can be bad, but when you start having a lot of failures, that raises the question of how good this disease, of our understanding of the disease, if we tackle it the right way therapeutically, and also if success can be achieved with the tools we have, in particular for assessing the endpoints. And that is a very, very complicated discussion because pathology is much more, the reading in pathology is much more random than what we thought before. And there's data for that. Anyway, those are the failures in the field for phase 2B and for phase 3 trials. So phase 2B trials failures are not good, but phase 3 trials failures, that hurts a lot. And it hurts the whole community, including the investors. And this is why it's a very, very bad time, I think, from what I hear around me, for NASH development. No, nonetheless, let's celebrate at least one big success, because this is the only phase 3 trial that was successful so far, obeticholic acid in the regenerate trial. So, and it was positive, and this was a success. Unfortunately, didn't yet bring 3 years later to the approval of this drug. And probably it has something to do with not so much the margin of efficacy, the size effect, but also more probably the balance of efficacy versus tolerability, safety, and so on. Nonetheless, this is a very large study, phase 3 study, has shown on almost more than 900 patients an effect on fibrosis, significant reduction in fibrosis. And not only less people, more people had fibrosis regression, but also less people had fibrosis progression, which is also very important to consider, and it's not formally in the outcomes. So all in one, this shows that using FXR agonists, for once, the animal trials were right. There seems to be an antifibrotic effect. And what I would like to stress here, because this is of utmost importance, is that the effect, a lot of phase 2 trials are positive. Very few of them are also positive in phase 3. So this is the first case where a positive phase 2b trial was confirmed in a larger international phase 3 trial with a much larger number of patients. And that is absolutely remarkable. And in fact, this is what is missing for everything else Sven mentioned before, including pioglitazone. Two-stage fibrosis improvement, very few patients, but much more than placebo. And also this drug had an effect on NASH resolution, in my opinion, even though formally there wasn't a difference. We can go into that in the discussion section if needed. Very important. So the study is still ongoing. That was the interim analysis. So now we're waiting for clinical outcomes and for more documentation of the effect at the interim and for more documentation of safety. And maybe then the FDA will issue a positive recommendation. Now, what is also very important is that this drug has also been developed for people with cirrhosis, which are those that had highest need of treatment in compensated cirrhosis. And this trial is ongoing, actually fully recruited, almost fully completed. And the results will hopefully be available a little later this year. And then we'll see whether there's a benefit at the cirrhotic stage. It's a whole other ball game to treat people with cirrhosis. Very, very ambitious project. But it's also very rewarding because those are the people, again, that have the highest risk of having deleterious outcomes from their disease. What I find interesting is that there's been some recent data explaining how FXR agonist reduces the amount of liver fat. So this is a very nice study that looked in a very systematic way, both the hepatic and the intestinal effects of FXR agonists in animals. And it showed that there is clearly a reduction in some lipid species in the liver, in particular, triacylglycerols, in particular, the monounsaturated fatty acids and the polyunsaturated fatty acids. And by doing a very extensive screening of all the different enzymes involved in the lipid handling in the liver, the authors were able to show that treating with an FXR agonist in the liver actually reduced the amount of tags, but basically only operating through 3 key enzymes of lipogenesis and lipid handling, and those are SCD1, LPIN1, and DGAT2. And you can see here striking differences in animals treated with FXR, and actually also in humans, because part of the study was done in humans. So the results are the same in the 2 species. And of course, animals that lack FXR knockouts, you don't see this effect here. So until now, it was believed that FXR agonists might work through an inhibition of SREB1C. This study demonstrates that the effect is independent of SHIP and SREB1C. Now, what is really interesting is that the authors also examine what happens in the intestine, because what happens in the intestine somehow creates a very complex picture. You all are aware of some studies that have shown paradoxically that FXR agonists in the intestine specifically increases the amount of liver fat. In fact, what they have shown is that FXR activation at the intestinal level decreases the lipid absorption. And they've done that through different ways, which are very interesting. First of all, they looked at the incorporation of olive oil spiked with radio-labeled 14-carbon triolene. And you can see here a reduction both in plasma triglycerides, so circulating plasma, but also in circulating free fatty acids in animals treated with FXR agonist. And another way to demonstrate that was looking specifically at what happens at the absorption at the enterocyte level. And you can see in the bottom part of the slide that they looked at the fluorescent fatty acid imaging of the intestinal villi, and they demonstrated a reduced signal in the jejunum. So basically what happens, and also what is interesting though, is that all this phenotype of reduced intestinal absorption of lipids was rescued by bile acid administration in these animals, in particular by cholic acid. So basically what the study shows is that there are at least two ways that combined achieve a reduction in the amount of liver fat. And this the combination is required for the full effect of hepatic defattening. And that involves both an inhibition of the lipid absorption in the intestine due to a decrease in the bile acid pool that reaches the intestine, and a reduction in certain enzymes of de novo lipogenesis and lipid handling in the liver, seems to be independent of SREB1C. So the mechanism of the anti-steatotic action of FXR seems to be well established that way. Now, the problem with the FXR agonists, though, is that they have side effects that can be a problem when treating long-term patients with NASH. That's why there was a whole rush until maybe 1 or 2 years ago to develop second-generation FXR agonists, which are non-biliary based FXR agonists, which were supposed to have either be more potent pharmacologically, highly selective, no TGR5 activation, and most importantly, to have less side effects. The side effects that are problematic: pruritus, LDL increase, and maybe also the increase in bile lithogenicity. So many of these second-generation non-bile acid FXR agonists have been developed and reached the clinical stage in humans. And you can see here some of the publications of these. And for instance, there was a lot of very strong argument in favor of using these because when compared with OCA in animal models, they seem to be more potent than obeticholic acid, which is the first in class. This is one of the studies that show that, and you can see here, if you look at tropifexor, here in pale blue, that it achieves a reduction in triglyceride amount in the liver much more than OCA does. It reduces collagen content, it reduces ALT much more than OCA does. So at least in humans, they seem more potent. Now, is this going to translate in improved side effect profile? Well, there were some signs that told that maybe not, because this study, which I found very interesting, looked at mice with humanized liver. And actually they tested OCA, which is the parent compound, versus two other FXR agonists, which are non-steroidal FXR agonists in contrast to OCA. And in fact, what happens is that those non-steroidal FXR agonists still have the same molecular targets, since they reduce CYP7A1, they increase SHIP, and this is done in mice with humanized liver. So there is no contribution from the intestinal FGF15. And despite that, the increase in LDL and the reduction in HDL was just the same as with OCA. So those were the first studies that have shown that maybe the problem, at least for lipid disorders, won't be fundamentally changed by using second-generation FXRs. So now that we have the results of the different trials, so we have tropifexor, cilofexor, we have this one is called venofexor, the metacrine and the Ananta products. All of them now have been published, and they show the emerging picture of what second-generation FXR agonists bring to the table is that they might have an effect on liver fat, which actually could be stronger than that of OCA. Apologies. They might reduce ALT, although some of them are less potent than others, depending on the pharmacokinetics and the half-life. Their effect on circulating lipids still exists. It is smaller than that of OCA, but there's still an increase in LDL. However, the big disappointment is that pruritus is still there. It's still there, it's dose dependent, and therefore is dose limiting, forcing you to reduce the dose if you want to have a good tolerability profile over the long term. These drugs, in contrast to OCA, and I don't really know why, induce weight loss, quite consistently, not a big weight loss, 2 to 3 kilograms. And one interesting aspect, at least for one of them, which is vonapexor, these data have been presented last year at the American meeting, is that they might have renal benefits in terms, in particular, of increasing creatinine clearance. However, the problem is that despite a strong effect in the animals, a strong target engagement, the weight loss, there doesn't seem to be clear histological benefit. Actually, only one of these compounds has been looked at in terms of histological effects, and that is tropifexor. But it was tested for 1 year. 1 year is long enough. As Sven showed you, you can see some effects even at 6 months, and then there was no effect of tropifexor on liver histology. Now compare that to pioglitazone, which was 96 weeks, so 2 years. Compare that with OCA, which was 1.5 years, so 1 year might not be enough. Still, there is no clear histological efficacy. Now, I'm not going to explain to you, because this is a very educated audience, that once you have FXR agonism in the intestine, what happens is there is a release of FGF19, which then engages the FGF receptor 4 in the liver, and then has almost convergent effects as FXR activation, hepatic FXR activation. So another drug that has been developed is a modified FGF19 compound that signals through pERK in order to keep an inhibition of the bile acid synthesis and have metabolic effects, but does not signal through STAT3. So therefore, in theory, no risk of tumorigenicity. And this compound called aldafermin has been tested in humans as well. Several studies are now available, and they have all shown a strong reduction in liver fat content with this compound, a strong reduction in bile acid synthesis, as you can see here, and a reduction in liver fat content. Now that went together with a biochemical improvement, which is pretty strong and sharp here. You see much more than you see with some second generation FXR agonists. And that went together with a resolution of steatohepatitis numerically higher. And when you look at, like with lanifibranor, the two together, the composite endpoints, a clear significance in favor of the drug for fibrosis improvement and NASH resolution. Now, all these are small trials, so taken individually, not all of them are significant, but to me, those are very encouraging results, and therefore it is surprising that this drug doesn't seem to be developed further, at least for non-cirrhotic NASH. I will now look at another important component of important new agent in development, which are thyromimetics. Because this is very interesting in the sense that large epidemiological studies have shown, surprisingly, that people with low thyroid function are at increased risk of NAFLD. If you look at the study here comparing strict normal versus low thyroid function, you can see that a lot of metabolic parameters or metabolic comorbidities are increased in patients with low thyroid function, but also the prevalence of NAFLD and specifically of advanced NAFLD in terms of fibrotic NAFLD are increased. And when you compare people with normal thyroid function, so strictly normal thyroid function, to those that have normal but low normal or subclinical thyroid function, you can see there is a considerable increase in the risk of NAFLD in those that are not normal. And then if you look in terms of what does that change for the patient outcomes, some studies have suggested an increase in overall mortality, cardiovascular mortality in patients with low thyroid function and NAFLD. So all these data combined with some biological data that show actually that there might be some level of tissue hypothyroidism in people with NAFLD have led to the testing some compounds that are thyromimetics. But before going to that, let me just briefly explain to you that you all know that the active hormone is T3. T3 results from the degradation of T4 by one particular isoform of a deiodinase, which is deiodinase 1. But then there's also a deiodinase 3. And the problem with deiodinase 3 is that instead of providing the active form, it provides the reverse T3, which is an inactive form of thyroid hormone. And what does that have to do with NASH? Well, it does, because some data have shown, at least in the animal, that the more liver damage you have, the more liver injury, the more active deiodinase 3 is, and the less active deiodinase 1 is, resulting in a situation where as liver injury progresses, there's less synthesis of the active thyroid hormone component, T3, and more diversion towards an inactive form. So thus contributing to a tissue level hypothyroidism. So that's why it is tempting to develop a drug that would compensate for this tissue level hypothyroidism. However, that drug that you may want to develop should be a very selective liver specific drug. So that only engages the beta thyroid hormone receptor, not the alpha, for reasons that are clear here because of the side effects induced by the alpha subtype of the receptor. However, if you're able to engage the liver beta receptor, that will reduce lipogenesis. Apologies for the typo. It will reduce LDL-C and triglycerides. It will increase mitochondrial function and biogenesis. It will increase lipophagy and beta oxidation, also autophagy, which is deficient in NAFLD. It might have some antifibrotic effects that I'll discuss a little later. Although it should be here. Oops. Yeah, okay. So that's why, and there are very few selective beta thyroid hormone receptor drugs that have been developed, but one of them is resmetirom that has been extensively tested in phase 2, and the phase 3 trial is ongoing, fully recruited. We expect the results for this year. So it's going to be hot. It's going to be the next drug that will report phase 3 results. And the results that we have so far come actually from short studies. Apologies. I have a little cold. 36-week studies here, placebo versus resmetirom, you can see here. And to make a long story short, very strong anti-steatotic effect of the drug versus placebo. See the proportion of patients achieving a reduction of liver fat that is predictive of probably histological improvement is much higher than placebo. Strong effect on the biochemical response as well, and also beneficial in contrast to FXR agonist, beneficial in terms of lipid reduction. All atherogenic species, LDL-C, all of them are listed here. They are improved by this drug. Now, in terms of histology, that's still a little bit unknown because the data we have are short-term, week 36, which is 9 months, and on a smaller number of patients. But they're very encouraging because the proportion of people who have resolution of NASH is much higher than in placebo, as you can see on the slide. But also what is very interesting, and this study has contributed to demonstrate that, is that the histological improvement seems to be determined by the amount of fat removal from the liver. So in other words, if you compare, and that's what's shown here, left, if you compare left, people with strong steatosis improvement, so more than 30% steatosis reduction, to those that less than 30%, non-responders, put it that way, you can see that the proportion of improvement in all categories of liver injury, whether it's steatosis, of course, by definition, but also ballooning, inflammation, fibrosis, all of them improve more in patients where you're able to defat the liver. And not only at the 30% threshold, but the more you defat, like some people achieve 50% reduction in steatosis, the higher the improvement in these different parameters here, parameters of liver cell death, liver cell injury, or inflammation. So it might be just this mechanism of action where you have a correlation between how much fat you can take out of the liver and how much you can improve inflammation and fibrosis. But it might be a more general mechanism. We'll have to see what happens in larger data sets with other drugs as well. Now, that's fine, but if that does not induce an improvement in fibrosis, it might not be enough even to reach the endpoints for phase 3 trials. That's why it is very important to know whether there is an antifibrotic effect of thyromimetics. I found one interesting study that shows that thyroid hormone, especially T3 here, can mitigate the antifibrotic response, the fibrotic response induced by carbon tetrachloride. And you can see here differences. So in terms of area of fibrosis, the response to increasing aminotransferases and also different genes that are pro-fibrogenic genes, the reduction in collagen, etc. So actually what happens is that T3 represses some signaling pathways that are operating in pro-fibrogenic way, in particular by stimulating TGF-beta target genes, and it represses TGF-beta induced pro-fibrotic actions. So this might be a way through which thyroid hormones, of course it has to be tested with this particular thyromimetics, might induce a regression of fibrosis. Another interesting class of agents that are now in development for NASH are agents that block lipogenesis. So as you know, de novo lipogenesis only accounts for 15 to 20%, 15 to 20% of the amount of fat in the liver. However, it is strongly induced by consumption of fructose or fructose-containing sweeteners, and therefore blocking de novo lipogenesis seems to be an attractive thing to do if you want to reduce the amount of liver fat. Now you can block that at different levels, and actually different enzymes have been targeted by specific inhibitors, such as the ACC1 and 2 inhibitors with firsocostat, another one blocking fatty acid synthase, and another one blocking steroyl-CoA desaturase. And this is one way that is being activated. So for instance, if you look at the study that has published with Aramco, which is a conjugate between a bile acid and a lipid, you can see that was an international study, tested 2 different doses. And you can see that there was some histological efficacy here in terms of resolution of NASH, some dose response in terms of improvement in fibrosis, even though the study was not powered for that particular outcome. And there was a strong response in terms of biochemical improvement. So this might be an interesting way to block the progression of NASH. Now, there are problems with using this type of drugs. And if you go back to inhibiting ACC1 and ACC2, the main problem here is despite a good anti-steatotic effect, despite a good anti-fibrotic effect, at least seen in animals, there is an increase in triglycerides that seems to be mediated through an increase in SREB1C because of a too strong reduction in the polyunsaturated fatty acids. Now, a way to meet, and that means that this drug cannot be used for treatment in patients with NASH. So people are then looking at different ways to mitigate the increase in triglycerides due to ACC inhibitors, which would allow them to use the ACC inhibitor, but in a different way. So one of these strategies is to combine it with a DGAT2 inhibitor, and the study was published recently. And you can see that indeed, when you use the combination of 2, there is no longer an increase. So here in blue is the ACC inhibitor, and then here in green is the DGAT2 inhibitor alone, which is not efficient for NASH. But then if you use the combination of 2, which is in purple here, you can see that there is a much smaller increase as compared to the ACC inhibitor alone. And this has been shown in the animal because actually there's much smaller induction of SREB1C activity with this combination. However, what is a little disappointing is that there is no gain in terms of efficacy as far as the reduction in liver fat content. Now, there's another interesting way to mitigate the effect of, yes, I'm almost done. There is another interesting way to mitigate the effect on hypertriglyceridemia with an ACC inhibitor, is actually to inhibit the degradation of ACC1 instead of promoting phosphorylation, which inhibits the activity. So you reduce the degradation of ACC1, and actually that is done through drugs that work through ALOX12, ALOX being arachidonate 12 lipooxygenase. So that achieves a much smaller reduction in the amount of available ACC. Instead of 90% reduction, achieve 50% reduction, which then does not increase SREB1C, which then does not result in increased triglycerides. So those are the latest data that have been generated for this latter one only in the animal, but that look very promising for the future. And I will end up with some other interesting molecule. You know that people with NASH and NAFLD have an imbalance in the amount of fatty acids, the omega-3 fatty acids and omega-6 fatty acids. And actually, that was an incentive to test omega-3 fatty acids in people with NASH. Well, those trials have failed so far with EPA, and the trials have failed histologically. So now a new compound has been created, which is called icosapbutade. And in contrast to EPA, it has been structurally modified in such a way that it does not incorporate into the membranes of the cells. And therefore, it's not susceptible, and it's less susceptible to peroxidation and to the damage of those membranes. And because it doesn't incorporate in those membranes, it accumulates outside the cell, outside hepatocytes, instead of inside hepatocytes in the lipid membranes. So icosapbutade is a promising molecule because of this structural. So it activates actually the fatty acid receptor 4 on inflammatory cells. It doesn't accumulate in hepatocytes. Therefore, it doesn't reduce the glutathione levels, so no increased oxidative stress. And it does have antifibrotic effects. And by stimulating these inflammatory cells, Kupffer cells and M2 macrophages, it has actually anti-inflammatory effects, which are shown here in this slide here. This is work from Detlef Schuppan's lab. So these type of structural modification of omega-3 fatty acids might be an interesting molecule for the future, and it is actively tested now in a phase 2A trial, and with probably a phase 2B, which is planned to start soon. So there are many unanswered questions yet. Is it sufficient, like I've shown with these different molecules, to target a single pathway? Or because of multiple redundancy in pathways, only combination therapy might end up being effective? Most drugs have pleiotropic actions, and the best example is FXR, and therefore it's difficult to determine which effect has higher chances of success when you plan a trial and when you plan an interim analysis. We don't know, and I didn't discuss FGF21 because I thought Kitty Peterson will your previous speaker will detail the FGF21 from Akiro. But is there a place for metabolic drugs that control for metabolic dysfunction but do not induce weight loss, contrary to GLP-1s? Are they still going to be active? And of course, you all know that the pegfilfermin data are negative. This was a FGF21 from Bristol Myers. Does an improvement in metabolic dysfunction translates necessarily into an anti-inflammatory hepatic, anti-inflammatory, antifibrotic benefit? There are issues with pathological reading, but we're not going to go over this today. Does an effect on steatohepatitis results reliably on an effect on fibrosis? Normally, the answer should be yes, but the 1.5 year data from the semaglutide trial did not show an improvement in fibrosis, despite a very strong weight loss and a strong improvement in strong resolution of steatohepatitis. And how long would that take? Does it take more than 1.5 years? Does efficacy on histological surrogates translate into clinical benefit? And this is what the phase 3 trials are about, particularly the outcome phase of those trials. Will it be possible to complete these large outcome trials? Those are 5 to 7 year trials. And it's hard to keep a patient on placebo for so long, but if you don't do that, then you won't have a positive result at the end of the trial. And then, of course, the OCA story tells us that it is not always easy to objectively define risk benefit. However, let's hope that 2020 will be the first successful year when we'll have a drug approved for NASH. And the two candidates that look closest today are, of course, resmetirom and semaglutide. So I'll stop here, and I'll be happy to take your questions.
Thank you very much, Vlad, for a real tour de force, running over this extremely crowded but also complicated field of new drugs. Let's see if there are any questions. I see Kit has a question for you, Vlad.
Yeah, I do. Yeah, thank you for your talk. It was a wonderful overview. Thank you very much. I think from what we know and what we've learned, and certainly in this meeting over the years, and certainly this meeting especially, is that we should probably educate the FDA to understand that we need to reverse hepatic steatosis before that develops into fibrosis. And NASH and fibrosis is a hard-end issue. We're still waiting to see if some of the treatments, and certainly what we're thinking about is the uncouplers to reverse hepatic steatosis that clearly reverse fibrosis in rodent models, and whether that translates to humans, we will find out very soon. But I do think we need to tell the FDA that hepatic steatosis is where it begins, and it's relatively easy to get rid of it and then prevent in that way.
I don't think we will be successful in doing that, because it all makes sense scientifically, what you say. Of course, it all starts with steatosis. But there are two problems. First, a lot of people with steatosis do not have any liver damage. They just have plain fat in the liver and nothing will happen. And we see that all day long in clinical practice. And therefore, it will be very difficult to treat with drugs, which will be new drugs, which will be not repurposed drugs, but drugs that are developed specifically for NASH, that will cost a lot, an arm and a leg, to treat everyone that is not at high risk of developing, progressive disease. So I think that would be a very strong
cardiovascular risk already, So I do still think it's worth pushing, and that's where we're going to have to go when we meet Hannele again in 10 years from now, that we will have made some progress in persuading the rest of the world that we developed the metabolic syndrome very early on in the progression of fatty liver, and start there. And I'm not, I know the challenges with NASH and fibrosis, absolutely, and can that be reversed or whatever? Yeah, okay, different issues, but just a point.
Question is yours.
Yes. No, I have to rush to another conference. Congrats, Vlad, also to the other speakers before, also regarding the clinical studies, which are really high quality that you also performed. What do you think? And we discussed that in a way. What do you think about combinations? Of course, combinations are difficult because companies do not like to share novel drugs, but that could be combinations even with drugs out of license. There's GLP-1 drugs that you mentioned, of course. There's pioglitazone. Maybe combinations would be very good. So what do you see in terms of potential combination therapies together, maybe with lifestyle, which Shira has so nicely presented, lifestyle and diet? So of course, we would need markers. What do you think about this? Personalized therapies guided by markers. We have them for cardiometabolic complications. We do not really have them that well for fibrosis as a hard endpoint. So what would be your future scenario? Of course, we cannot treat every patient with very expensive medications, patients who might be resistant to dietary and lifestyle changes. So what is your, let's say, future scenarios in terms of managing patients, perhaps with drugs in combinations?
This is a very feel-good, wishful thinking for combinations. Of course, you're right, again, theoretically. I'm waiting for a combination that works better than its individual parts. And for the moment, I haven't seen any. I've seen failures, total failures, like cenicriviroc and tropifexor. I've seen data, semaglutide plus plus cilofexor, semaglutide plus the ACC inhibitor, which doesn't bring much over on top of semaglutide. So yeah, an ideal combination would be certainly effective for them, but we have to find the right partners, and it'll take time. The other thing is the feasibility of combination trials. If the FDA, for the moment, they didn't make up their mind, but if they want a factorial design in a phase 3 trial, that will be impossible to do because it will take 10,000 patients or so. So forget about it. There will be no combination phase 3 trial. So then you can combine on your own once the stuff is on the market. As far as management, of course, I think a very important thing to understand is that diet and lifestyle measures are very good preventive measurements for NASH. Once you have very advanced liver disease, it might not be enough, but the preventive measures for sure work.
So very quick question on top. Of course, in Litmus, we are developing these surrogates. So what would you think about, and we had an initiative at least, which was finally not successful, to use out of licensed drugs together with some lifestyle change guided by biomarkers for inflammation and fibrosis. So why is that not an initiative that could be taken again versus the EU, for example? And we have developing surrogate markers now, which appear to be pretty okay, maybe not approved yet by FDA and EMA, but we may be convinced that they might be good. What do you think about that?
I think that's the way to go for sure, because with the liver biopsy, we won't be able to license any drug unless we're totally lucky, like we hope we'll be for resmetirom. But honestly, in my opinion, the liver pathological reading, we won't be able to license drugs. So therefore, two things, either AI reading, digital pathology reading, or biomarkers, as you say. The problem with biomarkers is, okay, you can qualify them by the FDA, but you will only qualify them for the moment for diagnostic purposes, not for measuring treatment effects. And that will take a long time. That's the way to go. And hopefully a few years from now, if we have enough movement in those biomarkers in relation to histological improvement, maybe that'll be enough, but the agencies won't be easy to convince.
Yeah, but that's the task for us as a task force, maybe to think about these things, not naturally in the high interest of pharmacological companies who want to earn a lot of money with a disease that does not necessarily need some kind of medications. Resmetirom, of course, would be a good deal potentially as an add-on drug, but it's still very expensive, etc. So I think that's something we all should think about.
But Detlef, you know just as well as me that we can't do these trials without the pharma companies because they have the trials. So what you need is a trial where you've got histology and the markers.
Sure. Yes.
We don't have that.
Or we have to. Yes, we have to found a combination pharma company altogether, get the venture capital, do the studies with the aid of the EU, something like that. Just food for thought. Okay.
Okay.
So I have to say goodbye because I really have to rush for a conference.
Incorrigible optimist.
Okay. So it was a very nice conference. Say goodbye to you and hope to see you soon again.
Maybe a last question, Vlad, from my side. The icosapbutate, right? That's this new drug. I noticed it's alpha blocked. So this is something that was already tested in the lipid field many years ago with drugs like Medica 16 and a TTA from Rolf Berge or alpha bromopalmitate. They strongly activate PPAR alpha, and we just heard from Sven what that may or may not do. So I was just wondering, I'm pretty sure this drug will activate the PPAR system as well because it's alpha blocked, but nobody ever tested it in combination with a unsaturated fatty acid chain. So is there any data that indicate that the unsaturated moiety is important in any of the effects so far described with this drug?
So I stayed in here because we did these studies, as Vlad mentioned. So a major effect is via GPR 120, omega-3 fatty acid, the major receptor. And there is, of course, there is some PPAR alpha activity, which is not overwhelming. And it appears to be mainly active on activated macrophages, which have this kind of receptor in abundance. And of course, it's the major point is it's not metabolized itself, of course, but it activates PPAR alpha, and it's not integrated into lipid membranes of hepatocytes, etc. So that also makes it definitely more effective, and it generates a panel of anti-inflammatory mediators, oxidized, unsaturated fatty acids, etc. We have in that study, we have a little lipidomic analysis. So it's not all explored. And as you also state correctly, it has been tested in type 2 diabetes. This is the study that we also referred to in our mouse study to have correlative data in people with elevated transaminases and the FIB score. But you are absolutely right. There's PPAR activity.
Yeah, I was just wondering if anyone tested the same molecule, but in the saturated version and compared then the activity.
I think it was definitely done, but a major activity definitely is by the unsaturated omega-3 fatty acid receptor.
Yeah, that's interesting. That had not been tested before.